Hello, my name is Dr. Arinze Ikeme or Ikemi. I am a hospitalist and nephrologist. I practice both. I'm also an associate professor with Campbell University in North Carolina, and so I do teach medical students. I today I want to talk about evaluation of hyponatremia at the most basic level. This is not a discussion for nephrologists, though they can learn from some of these basic concepts. But this is really a lecture for, hospitalists, internists, medical students, or other providers, physician assistants, nurses, or anyone who is involved in managing this common electrolyte abnormality. And this is just the basics to guide you in how to look at it. To help you figure out what's going on and, of course, come up with some treatment plan. So, I'm going to be discussing the definition of hyponatremia, the physiologic regulation of sodium and water balance in the body, the importance of history and physical examination in your evaluation of hyponatremia, lab tests in evaluation of hyponatremia, and the algorithm in evaluation of hyponatremia. Again, this is not exhaustive, but it will help get you started to figure out what's going on in these cases. So, by definition, hyponatremia just refers to low sodium levels in the blood on routine lab tests. So, the normal sodium level is 135 to 145 molar equivalent. Hyponatremia is diagnosed when the sodium level is less than 135, and so symptoms usually would start once the sodium is less than 130. Of course, if it's 134, even though it's low, we hardly bother about it. But once it starts dropping to the 130, 129, 128, then we definitely want to know what's going on so we can prevent it from getting worse. So first, let's look at the regulation of the sodium and water balance in the body. I do want to mention that sodium and water balance are independently regulated. It's not the same system, but they are regulated by mechanisms that are designed to maintain effective arterial volume in the blood, arterial volume, and plasma osmolarity. So these are priorities. These are parameters the body is trying to maintain: effective arterial volume, of course, for perfusion of all the organs in the body, and of course the plasma osmolarity is also being maintained, because of course when there is a disruption in the osmolarity in the plasma, fluid exchange happens, and that might be detrimental to some cells in the body. Most cases of hyponatremia are due to reduced water secretion in the kidney. So, the kidney retains more water or doesn't secrete more water, and so the sodium drops because the body tries to maintain a good sodium water balance. But there are other mechanisms that apply, of course. So the regulation of sodium and water balance, there are organs involved, like the hypothalamus, pituitary axis, and the kidneys are involved in water sodium balance. And there are hormonal signals, the renin, angiotensin, aldosterone system, the antidiuretic hormone, which we also call the vasopressin. These are regulators of sodium and water balance in the body, but we'll see how that happens. Okay, so let's look at the sodium balance. It's regulated by sodium intake, so absolutely, and sodium loss or retention. So if there's an imbalance between the sodium intake and the loss or retention, then hyponatremia can occur. So as far as the loss or retention of sodium, there can be renal loss or retention affected by aldosterone effect in the distal tubule, as well as loss and reabsorption at other parts of the renal tubule, including the loop of Henle in the kidneys. I'm assuming, of course, you remember your anatomy. And then outside the kidney, extrarenal GI losses from diarrhea, vomiting, or skin losses, especially with extensive burns. And the diagram up there is looking at the juxtaglomerular apparatus, which is pretty much, it's an apparatus that helps in regulation of sodium water balance in the body, and it's located where the glomerulus, especially the afferent arteriole that forms part of the glomerulus, meet together, or they're in close proximity with the distal tubule. And so the macular denser cells of the distal tubule of the nephron is involved, as well as the juxtaglomerular cells of the afferent arteriole of the glomerulus. And so they form kind of a complex called the juxtaglomerular complex that you can see. It's sensitive to the urine flow in the tubules. It's sensitive to the blood itself, the blood flow. And so it senses the changes in osmolarity as well as the perfusion, the arterial blood volume. And so once they sense that, then they trigger the renal angiotensin aldosterone system, which causes the kidneys to produce renin, which triggers the secretion of angiotensin that the lungs convert to angiotensin 2, which will trigger the release of aldosterone from the adrenal gland, which at the same time triggers ADH release and helps in modifying sodium or water absorption in the body depending on the situation. So this is just to mention that the kidneys are involved, and as you can see, the lungs are involved in some way, the brain is involved in some way. What about the water balance? Of course, we've mentioned the ADH. So, the water balance is regulated by the water intake and water loss or retention. And the renal loss or retention of water is affected by ADH or vasopressin, which has its effects on the collecting duct and later distal tubules in the kidney. And the extrarenal loss is the GI loss, the skin loss, or other insensible loss. And of course, this diagram again, as I said, the major regulators are the plasma osmolarity or the arterial blood volume. So if the plasma osmolarity is increased, so this osmolarity goes up, it means that the patient is dry, and so the plasma is concentrated. That would cause an osmoreceptor activator and stimulate the hypothalamus, which stimulates the posterior pituitary, produces ADH, as well as your thirst drive. And the ADH goes to the kidney and causes increased water absorption in the collecting tubule. And that's how the body responds and tries to regulate water balance. So again, just as a general rule, if the serum sodium is low, the urine sodium is expected to be low. And so if the urine sodium is high when the blood sodium is low, then perhaps the problem is coming from the kidneys. That's a general rule that will help you figure out what's causing hyponatremia. So some of the typical lab tests you request in hyponatremia would be serum osmolarity, the urine osmolarity, the urine sodium, the thyroid stimulating hormone, the uric acid level, the serum protein level. So let's look at the algorithm in evaluating hyponatremia. So the first step is, what's the plasma osmolarity? Normal plasma osmolarity is 275 to 295 milliosmol per kilograms. And so you want to be able to triage your hyponatremia cases into hypertonic hyponatremia when it's more than 295 osmolarity, isotonic hyponatremia when it's within normal, and the hypotonic hyponatremia when it's less than 275, which, by the way, is where most of your cases of hyponatremia would belong. And then you break down to the possible causes. The hypertonic ones can be caused by hyperglycemia, mannitol, uremia. But, let's think about it for a bit. If you think of plasma osmolarity, there is a formula, to calculate the plasma osmolarity. And that formula incorporates all the substances or solutes that do contribute to osmolarity. And again, I'm trying to keep this as simple as possible. The formula is, 2 times sodium plus glucose over 18 plus urea, urea divided by 2.8 plus alcohol. So if you look at that formula, you realize that glucose is incorporated there, sodium is there, BUN or your urea is there, as well as alcohol. So these are things that contribute to osmolarity. Now, I'm not going to go into the difference between osmolarity and tonicity and what is effective osmol and stuff like that. That's advanced nephrology stuff, but these substances contribute to osmolarity. So if the sodium is low and yet the osmolarity is high in the hypertonic hyponatremia, it means that one of these contributors are high. So it could be higher glucose in hyperglycemia, high alcohol in the system, like those getting mannitol infusion, especially patients with intracranial bleeds in the trauma centers or neuro ICU, or uremia, people with high urea levels in the 100s. So this can cause hypertonic hyponatremia. Again, you're trying to figure out why the patient is hyponatremic. Of course, the hypotonic ones, you're thinking hyperlipidemia, hyperproteinemia, and the best easy way to explain that in the lay term would say, if the sodium is low, how come the osmolarity is normal? Since, of course, sodium is the biggest contribution to osmolarity. So if the sodium is low, why is this osmolarity normal? It just means that there is something else in the system that doesn't contribute to osmolarity, but is making the sodium look low. And it usually has to be something that doesn't dissolve or contribute to osmolarity, doesn't dissolve in solution. Lipids, protein, they are not soluble. So the easy way to say that is they kind of displace or add more volume to the solution. And so the sodium in solution feels low because it's measured as a whole. I'm hoping that makes sense. But these are situations where triglycerides are high, especially like in familial hypertriglyceridemia, where triglycerides can be in like the double digit 15,000, 10,000, or hyperproteinemia states like myeloma, multiple myeloma, Waldenstrom's macroglobulinemia, IVIG infusion. And actually, in cases of biliary obstruction, the cholesterol levels are real high, and the lipoprotein X is also really high because of the obstruction. And so you can have hyponatremia in those cases, but they are what we call pseudo hyponatremia because they are not true low sodium levels. And so the sodium is low. Again, they are isotonic. And then, of course, if they are hypotonic, that's where most of them will fall in. Then you want to go ahead and take your next step, which is the urine osmolarity. So a normal urine osmolarity varies, I would say on the average 500 to 850 milliosmoles per kilograms. But depending on whether ADH is stimulated, if it's minimally stimulated, where the urine is not that concentrated, is as dilute as possible, urine osmolarity can drop as low as 40, 50. If it's maximally stimulated ADH, then you can concentrate the urine to as high as 1400 milliosmoles per kilograms. So when you check the urine osmolarity, there is usually one condition I'm looking for, and that is primary polydipsia. When the urine osmolarity is less than 100, a patient is drinking so much water, either they have a psychiatric problem, very anxious and drinking a lot of water, or some people hear that you need to drink 4 gallons or 4 liters of water every day to stay alive or to stay young, and they drink more than they should. You can do that and dilute your blood to the extent that you have hyponatremia and the urine osmolarity drops to as low as 100, less than 100. And of course, that can also happen to those who are not eating much of solute in the form of protein or salt. There's a condition we call beer potomania, where they drink a lot of beer, which is very low on solute and very dilute fluid. And so they can have hyponatremia. And usually just restricting the fluids corrects the hyponatremia. So again, you've checked this plasma osmolarity, you've gone through the hypertonic ones, the isotonic ones, you're thinking hypotonic, you get your urine osmolarity and you rule out primary polydipsia, and then you continue. The next step is the volume status. So the next thing I do is I check the patient's volume status and I categorize them as hypervolemic, meaning they are volume overloaded, euvolemic, meaning their volume seems fairly normal, or hypovolemic, meaning they are dehydrated. Again, for the hypervolemic patients, I think liver cirrhosis, congestive heart failure, nephrotic syndrome, severe protein malnutrition, where the patients are swollen like kwashiorkor in underdeveloped or developing countries. So these people can have hyponatremia, and most times it's there is some ADH response. They have low effective intravascular volume because of TET spacing in these cases, and so the signal is that the body is getting dry even though it's going into the interstitial spaces, and so ADH can be stimulated and cause retention of water which can dilute the sodium if you have more retention than the aldosterone salt retention. That can occur, and these are poor prognostic factors. If you see hyponatremia in cirrhotic patients or CHF patients, the prognosis is pretty poor. And then, of course, the euvolemic cases, SIADA, syndrome of inappropriate ADH, or hypothyroidism that I might mention later, hypovolemic cases where you've lost sodium and water from the GI or from the kidneys or the skin. So when that happens in hypovolemia, the next thing I do is I get the urine sodium level. That will tell me whether the loss in hypovolemia cases is it from the kidneys or out of the kidney. If the urine osmolarity is less than 20, that tells me something. If it's more than 40, that tells me something. Okay. If the urine osmolarity is less than 20, then I have to think, I have to tell myself it's not the kidneys, wasting the salt. The low salt level in the blood, the hyponatremia, is not from the kidney. It has to be outside the kidney. So it could be GI loss from diarrhea or skin losses like burns, extensive burns. If the urine osmolarity is the urine sodium, is more than 40, yet the blood sodium is low, that means the kidneys might actually be where the problem is. So renal losses like diuretics, some people abuse diuretics, or even those who are on certain diuretics like hydrochlorothiazide can cause sodium loss, very common in the hospital. Adrenal insufficiency, especially when there is hypoaldosteronism and the aldosterone is not available to cause sodium reabsorption from the kidneys. You lose a lot of sodium in the urine and hyponatremia can occur. There are genetic situations, genetic causes like some people have heard of Bartter syndrome, Gentleman syndrome. These are syndromes where there are tubular dysfunctions that will lead to increased loss of sodium in the urine, almost like you're on a diuretic drip and they lose a lot of sodium in the urine. These are possible causes of hyponatremia when there is increased renal loss. Again, the urine sodium will end up being elevated. So again, as a general rule, I know it's difficult to remember all these, but as a general rule, you can follow this algorithm and you can get to the primary cause of your hyponatremia, which will let you know how to treat the patient. But as a general rule, as I said, if the blood sodium, the plasma or serum sodium is low and the urine sodium is high, then you should look into the kidneys and see what's going on with the kidneys there. But if the urine sodium is low, which you expect in low sodium levels, then maybe they are either not taking enough of solute, enough of salt, or they are losing it in some other ways, but definitely not the kidneys. So again, I hope this little algorithm, this little lecture would help you at least beginning to grasp how to go about assessing patients with hyponatremia so that you know exactly how to treat them. Yes, there are situations where there are a combination of factors. You might have to do a little more monitoring and you might need to get the nephrologists on board to help out. But for those simpler cases, this might actually help you figure out what's going on. Thank you.